Dr. Manuck also serves as the Perinatal Health Division Head at the Carolina Institute for Environmental Health Solutions. If you take one glance at her CV, you'll be immediately envious. She has almost 100 peer-reviewed publications, some of which she collaborated with members of our department here. Dr. Manuck is a recognized national leader in preterm birth research, particularly in investigating genetic and other susceptibilities to spontaneous preterm birth. We are really delighted to have Dr. Manuck here with us virtually today, and I'm looking forward to hearing her talk on racial disparities in spontaneous preterm birth. Tracy, welcome to UAB.
Thank you so much for that very kind introduction. I will share my screen here and get set up, hopefully without too many blips in the process. Can everybody see the slides? Okay, fantastic. Thank you, Brian, again. I will be speaking today about racial disparities in spontaneous preterm birth, which has become a recent passion of mine with regards to both research and clinical care. So today we'll talk briefly about epidemiology and some definitions, talk about the extent of the disparities and some phenotype information, delve a little bit into the why behind the disparities, and then talk about some of the long-term implications for maternal health and how we might be able to move forward and work towards some solutions. So as many of you probably know, preterm birth rates rose steadily in the United States in the 1990s and 2000s for women of all races until about 2005. And notably, you'll see the black line, which represents women of African American race here, remained consistently nearly 50% higher than that of Caucasian women. Throughout the talk, you'll notice that I may switch back and forth between using terminology African American, Caucasian, non-Hispanic white, non-Hispanic black, and that is because definitions have changed over the years. And so even though some of the terminology is outdated, this is what was used at the time. And I hate to be confusing and contradict what's on a slide and a graphic that was presented by original authors and original research. So again, between 2000 up until about 2005 or 2006, the rates of preterm birth went up, and then fortunately between 2006 to 2014, rates of preterm birth declined. But unfortunately, now we're on an upward swing, and the rates of preterm birth are rising once again in the United States. And this increase has been most significant among non-Hispanic Black women. If we define exactly what that risk is, instead of just looking at those bar graphs or that line graph, and try to quantify that risk, there was a very well done systematic review. Got a thing here trying to, back in 2013, looking at a number of different studies of women of different races using white women as a referent group, and found very consistent findings where Black women across 30 different studies had a composite odds ratio of 2.0 with a 95% confidence interval that was fairly narrow at 1.8 to 2.2 for an increased risk of preterm birth. With regards to women of other races and ethnicities, the results were mixed. Women of Asian ethnicity had some studies showed a decreased risk compared to white women, others showed an increased risk, and likewise with Hispanic ethnicity. Because of those results, today we are going to focus on the disparities between non-Hispanic Black and non-Hispanic white women in this talk. So this is just a summary of the results from that large review, which I think are really quite telling in that the odds ratios are all to the right of the line, which is 1.0 for the odds ratio, favoring an increased risk of preterm birth for non-Hispanic Black women. And again, that odds ratio is 2. Well, what if we think about women of other races and ethnicities outside of the United States? There's pretty limited data. A number of studies have been done looking again at comparisons versus women of non-Hispanic white race. Studies from Turkey showing no difference, studies from Morocco showing no difference, and studies in the Middle East and North Africa showing potentially even a lower risk compared to women of non-Hispanic white race. Well, to back up just a little bit, how do we define race? Well, the definition of race is somewhat inconsistent between studies, as I alluded to earlier. There are a number of studies that unfortunately mix or confuse race and ethnicity. Unfortunately, there has been a lot of attention brought to this, so there's been less of that as of late. But many of the studies that were done in the 2000s would refer to only women that were white and did not refer to any sort of ethnicity, or only women that were Black and not refer to any sort of ethnicity qualifier along with that race information. In addition, definitions have been changing. Even on the US Census information, there have been different boxes that can be checked from year to year. And this is changing, even from the year 2000 to 2010 to 2020. In addition, there's been a lot of debate and discussion about a biologic definition of race versus a social definition of race, and we'll get to that in just a few moments. Furthermore, most studies in obstetrics and in other fields use self-reported race and ethnicity, but there are a lot of questions about how good that really might be. I think many people have now come to realize and recognize that race really is a social construct. So in society, people note and assign significance to physical characteristics of others, such as skin color or hair texture, or other distinctive features. And race becomes socially significant when members of the society routinely divide people into groups based on the possession of those certain characteristics. Those characteristics then become socially significant as well when members of the society routinely use them to establish racial categories where people might be classified on the basis of their own or their ancestors' physical characteristics. And when that categorizations elicit different social perceptions, attitudes, or behaviors towards a group, including racism or even positive behaviors. However, there's also biologic definitions of race. And these biologic definitions were first developed in the 18th century by naturalists who studied population groups in relatively isolated geographic areas. And in modern times, researchers have discovered genetic clusters, and using this information, they've actually been able to classify individuals with zero a priori information regarding their population groups. And using that genetic information, they can group them into major geographic regions of origin and subclusters, again, corresponding to where their region of origin is. So I know this figure is very small on this slide. However, it is meant to demonstrate that just based on a certain set of genes and genotypes, there are the investigators do have the ability to determine a genetic area of origin. But even then, it is important to notice that and realize that within population differences account for only 93 to 95% of genetic variation, but there's only very small genetic differences between these different groups. So what we're seeing here is a very, very small percentage of one's genetic makeup. In addition, there's no distinct set of genes that corresponds with the social conceptions of race. So if we went back and thought about the last slide where we're defining a social construct of race as a Black skin color or a certain hair texture, for example, there's not a specific set of genes that would correspond to that specific finding. One way that researchers have objectively grouped subjects in studies is a technique called principal components analysis. And this is actually an example figure from one of the studies that I've worked on. And this may correspond with self-reported race and ethnicity, but in actuality, it really more accurately corresponds to one's country of origin. And the technique basically looks at the minor allele frequencies that occur in varying degrees among individuals of different countries of origin, similar to that last slide. And using that, principal components can cluster data and cluster individuals based on the genetic distance and relatedness, and provide a more objective measure if you're considering classifying individuals by race in a study. Further complicating matters, in modern studies, there's more heterogeneity, particularly within the United States, due to increasing population admixture. And by admixture, we're referring to the fact that the United States is a melting pot, and there are individuals from different countries of origin that are, marrying individuals from different countries of origin and reproducing, and this makes things even muddier. And this issue is going to continue to grow. As of 2016, 14% of the United States population was non-Hispanic Black, but the estimate is that by 2060, 18% will be non-Hispanic Black. And this might make ancestry informative markers or specific markers that are used to follow specific individuals from different countries of origin, that's less reliable in the future. And that principal components analysis I showed on the last slide, more difficult to group into distinct clusters. So this is just an example of kind of what we're talking about here, where individuals who are US born, when we look at the density of ancestry informative markers, the dashed line is, you can see is moving to the left. So they have a smaller proportion of genes or genetic material that is, distinctly from their country of origin. And as you can imagine, individuals who have just emigrated from a different country to the United States have a higher percentage of genes of their country of origin. In this case, in this study, African genes were evaluated. Well, what are we talking about when we talk about disparities? So according to the NIH, the definition of disparity is differences in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population subgroups. It's important to note a few key facts about disparities. So reducing the incidence of a disease like preterm birth is not equivalent to reducing the disparity associated with preterm birth. Reducing the disparity itself might require different actions above and beyond traditional disease prevention models or methods. So, and as of 2020, there's no evidence base for interventions to specifically address eliminating preterm birth disparities. So if we think about some of the interventions we've come up with for preterm birth prevention, and we know those are few and far between, if you believe that progesterone works, for example, for the prevention of recurrent preterm birth, even if it does reduce preterm birth, it's not specifically aimed at reducing disparities in preterm birth. So that would be an example of how an intervention for preterm birth is not the same as something that would reduce a disparity in the condition. Well, what exactly is the extent of the Black-white disparities in the United States? We know that the odds is about twofold higher, as I showed in the earlier slides, but there are a number of other differences and nuances that I think are important to realize. First of all, there are significant differences in pre-viable deliveries. Unfortunately, I don't have time in this hour-long talk to go into a lot of detail, but I'd like to highlight a few key studies in each one of these areas. So Emily DeFranco and colleagues from Ohio a few years ago published in AJOG a population-based study looking at over 1 million live births, and they compared the rates of birth at each week of gestation between Black and white mothers. They looked at pre-viable deliveries, and they compared them with full-term deliveries. Overall, during the study period, there were 2,600 pre-viable deliveries, which was a fairly large number, and that accounted for 3% or 0.3% of all live births. And the overall incidence was significantly higher, as you can see here, for Black mothers compared to white mothers. This again is an example of how studies refer to race and ethnicity differently. There was no reference to Hispanic or non-Hispanic in this study, which is why it's listed only as white and Blacks. 80% of the pre-viable deliveries were spontaneous, compared to a 73% of early preterm births between 23 and 33 weeks, and 65% of term births were spontaneous, occurred after spontaneous labor. The pre-viable births constituted 28% of total infant mortalities in white newborns, but 45% of infant mortalities in Black infants in Ohio during the study period, which led the authors to conclude that these pre-viable deliveries and preterm delivery were a large contributor to infant mortality and might explain some of the gaps in that area too. When they look at adjusted models for risk factors for pre-viable birth, they found multiple factors were associated with pre-viable birth. But notably, Black race was a significant risk factor and was a greater contributor than other socioeconomic factor variables such as marital status, and which is noted here with the adjusted relative risk of 2.1 compared to Black race, which was had an adjusted relative risk of 2.9. Additionally, they found that the relative risk of preterm birth at each preterm week of gestation was elevated for Black mothers compared to white mothers. And that these differences were most pronounced at the earliest gestational ages, with a relative risk at greater than 2 at these earlier gestational ages compared to white mothers in this cohort, which I think is really interesting because it seems as though the disparity here is really at these earliest, most profound gestational ages where we see most of our neonatal morbidity. We also see differences in phenotype, and some of these are seen with regards to cervical insufficiency, which goes along with the fact that we see more pre-viable deliveries among Black women, but there are other significant differences as well. So as I just alluded to, cervical insufficiency is more common among Black women who have a higher odds in the neighborhood of 2.5 to 3 in multiple different studies. Obviously, we know that there are some flaws to these studies where it's difficult to define cervical insufficiency or just define differently across different studies, and the confounders that are evaluated or controlled for do vary. But there's also a higher odds of a short mid-trimester cervical length among Black women. When I was a fellow, I did a secondary analysis of the Genomics and Proteomics Network study where we actually looked at a number of different phenotypes. We created the phenotypes using clinical data only for preterm birth, and we had over 1,000 women, and they were assigned at least one phenotype if they met criteria, but they could be assigned as many phenotypes as they met criteria for. And almost 80% had 2 or more phenotypes. Some of the phenotypes are listed here along the x-axis, and you can see that there were significant differences across a number of different phenotypes when we looked at African American and Caucasian women in this study, where again we saw that cervical insufficiency was more common among African American women, and maternal stress was also more common among African American women. And in contrast, we saw decidual hemorrhage and placental dysfunction was more common among Caucasian women, which kind of gets to the question of whether or not there are other differences physiologically with regards to the etiology, underlying etiology of preterm birth. We also note that there are some differences in recurrent spontaneous preterm birth. So when we consider the fact that a prior preterm birth is the largest risk factor for a recurrent preterm birth, we know that this factor is even more significant among Black women. And these data here are from Georgia. It's an older study that was conducted from 1980 to 1995. The researchers examined second pregnancy outcomes among approximately 2,100 women with their first pregnancy delivering between 20 and 31 weeks gestation, so a fairly early first delivery. And they found overall 30% of the white women and 37% of Black women had recurrent preterm birth. And Black women were more likely to have recurrent preterm birth between 20 and 31 weeks gestation, and were also more likely to have late preterm birth between 32 and 36 weeks gestation compared to white women. And these findings were consistent with other similar reports from other countries, and also in later reports here in the United States. The next study that looked at recurrent preterm birth that I just wanted to highlight was from California. There was a cohort, they included a cohort of 2.9 million women. They evaluated the first and second pregnancy outcomes for women who delivered their first and second pregnancies between 2005 and 2011. And they specifically set out to evaluate results by race and ethnicity. Among women who delivered their first infant preterm, the odds of delivering their second infant early differed, again, significantly by race and age. And Hispanic, Black, and Asian non-Hispanic women who are less than 18 years old for both pregnancies were at higher risk of having a preterm birth in their second pregnancy, with adjusted odds ratios that are shown here. Again, demonstrating this, this effect. So why are we seeing these racial disparities? Well, we all know that preterm birth is a complicated, multifactorial clinical outcome. But here's a simplified schematic with 3 highlighted possible etiologies to explain some of the differences that we may observe in race. I'd like to highlight racism and stress, the environment, and genetics as potential drivers of the health outcomes of preterm birth. So racism has gotten a lot of attention recently in the media and in society, which I think is wonderful, because that is the first step that we need in order to make positive change and reduce and eliminate racism. Unfortunately, there's no great universal way to measure structural racism. In a recent study that was performed in Michigan, researchers reviewed ways that other researchers have investigated racism across a number of a 10-year period of studies, and specifically searched PubMed for the measures that they used, that other researchers have used to evaluate racism's association with physical and mental health outcomes. And they found that the terms listed here were the most commonly used measures of racism. The leading term was, and the leading factor was looking at residential neighborhood and housing environment. Also looking at perceived racism in social situations, socioeconomic status, and criminal justice, and the other factors listed here. The problem with this is that the majority of these studies do not evaluate the impact on the individual, the response to racism, the coping mechanisms, or the impact that racism or the environment or one's socioeconomic status might have on that individual's life and therefore affect outcomes. For that, we have multiple published measures or scales to assess racism. And you may have used some of these in research or seen some of these being used or provided to some of your patients. In a very brief search, I found more than 30 different measures. Some of them are listed here. And all of them have pros and cons. Some of them have as many as 100 questions. They try to survey individuals across multiple different domains where they may have experienced racism. They may try, some of them include a historical racism, such as, did you experience this sort of racism or perception growing up versus do you experience this now in your daily life? But the problem is that there really is no gold standard, and it's very difficult to actually quantify. Well, is racism important for us to consider? And I think, I think overwhelmingly, yes, it is. Even if we are still trying to figure out the best way to quantify it, there are a number of studies that do demonstrate a relationship between racism and preterm birth. Again, just to highlight one of the studies that was performed using PRAMS data, a large data set from 2004 to 2012 that included data across 11 different states in New York City, almost 12,000 non-Hispanic Black women who had a preterm birth rate of 13%, which was actually even a little bit lower than you might expect. 14% of women in this cohort reported feeling upset by racism in the 12 months prior to delivery. And I think importantly, this study looked at if feeling upset by racism, if they had that sensation of feeling upset rather than just experiencing racism, which I think are two very distinctly different things, this was associated with an increased odds of preterm birth at an increased odds ratio of 1.29. When we talk about racism, oftentimes we talk about stress and the stress that racism might induce. And I think stress is another one of those conditions and another one of those things that is, the term is thrown around a lot in the literature, thrown around a lot in clinical practice, thrown around a lot in our daily lives. So we're in COVID times and we all talk about feeling stress and being stressed, but the technical definition of stress is sometimes difficult to actually put a finger on. But I like this definition that is listed as environmental demands that tax or exceed the adaptive capacity of an organism, resulting in psychological and or biological changes that place the organism at risk for disease. So stress has different effects, whether it's acute or chronic. In the acute phase, we all know that cortisol is related to the stress response, and cortisol will bind the glucocorticoid receptor and it will relocate that to the nucleus and bind transcription factors where it will repress transcription and the expression of pro-inflammatory genes and then it generally acts in a protective manner. So acute stress is not necessarily a bad thing. However, chronic stress is where we start to have problems. When stress is chronic, and the definition of chronic stress or the time period for that is up for debate, but from a biochemical standpoint, the glucocorticoid receptors become desensitized, and that pro-inflammatory gene expression then takes a turn in the opposite direction and increases. And in response to that, the organism, the individual's disease susceptibility increases. So this is thought to be one of the reasons why chronic stress may be associated with adverse outcomes and adverse health outcomes in general. However, stress is always a balancing act. So we think about the different things that can cause stress, abuse, financial worries, peer pressure, racism, discrimination, but then, counterbalancing that is the positive things like social support, adequate education, and coping skills, physical and psychological health, and then one's social environment in general. And indeed, when we look at how social stress relates to preterm birth, there was a study in Canada that looked specifically at stress, and also looked at whether or not individuals who had some of those positive coping mechanisms, such as social support and optimism, had improved outcomes. And in fact, those factors were found to be protective. So if individuals were reported to be under significant stress and had biochemical evidence of stress, they were at significant risk for preterm birth with an increased odds ratio of 1.73. But those who had low levels of social support and low optimism had even higher risks of preterm birth. And finally, shown here is a schematic or kind of a possible framework for how we might think about racism leading to stress and then leading to preterm birth. So if racism becomes chronic, and is a chronic problem in the United States, it can create chronic stress, can create a profile of increased stress hormones, which are then produced even in higher amounts in response to additional pregnancy stressors, increased pro-inflammatory gene responses. And as we all know, preterm birth is pro-inflammatory. Maybe that contributes to some of the cervical remodeling and the cervical insufficiency that we see in higher rates among non-Hispanic Black women. And maybe that is one possible mechanism or pathway by which racism and chronic stress may contribute to preterm birth. Next, I'd like to talk about the environment and how that may contribute to some of the disparities in birth outcomes. So studies of the environment and prematurity and disparities are complicated because it's oftentimes really hard to disentangle the different effects, the individual, the neighborhood, and the potential pollutant. And in this case, in this study that I'd like to talk about, air pollution. So this was a study that was done in California with some birth data, and the investigators looked at the risk of preterm birth and other adverse birth outcomes, and compared the risks between, compared the outcomes between non-Hispanic Black mothers and white mothers. And they compared a number of different factors, such as individual factors, neighborhood level factors, and air pollution predictors. They obtained neighborhood level data from 2010 census information at a zip code level in order to get their neighborhood context. And they got air pollution data from the US EPA and assigned that at a zip code level as well. And they found that there were a number of different individual or social level predictors that are listed here, as you might expect: education, maternal age, use of Medicaid, missing paternity information on the birth certificate. A number of different neighborhood predictors, including the employment, education level, again, whether or not they were English speaking, and whether or not the neighborhood was classified as privileged or deprived. And then again, another different level of air pollution predictors that are listed here, looking again at particulate matter and nitrogen dioxide. And they found that the risk of preterm birth was overall 10.9%, and it was higher in Black women at 15.7%. And they really tried to determine whether or not the socioeconomic predictors, the neighborhood predictors, or the air pollution predictors were the biggest contributors. And they basically concluded that individual contribution was of the mean particulate matter exposure was comparable in magnitude to any single individual or neighborhood level factor. They really found that surprisingly, there was still a very large amount of preterm birth that remained unexplained. I'd like to also talk about, when we talk about the environment, looking at women of high socioeconomic status. So if we take some of those factors out of the equation that we just talked about in the California study, and we consider women who would be expected, at least on paper, to have a really low risk of preterm birth. These data were presented by Jasmine Johnson, one of our fellows last year at SMFM in the fellows plenary, and have subsequently been published in AJOG, looking at national vital statistics data. And we defined high socioeconomic status as women who had at least 16 years of education, private insurance, and were not receiving WIC benefits. And they had to have all three of those factors to qualify as being of high socioeconomic status. So from our study population, from all the live births, which were about 13 million, 2 million met those study criteria. The vast majority of the study population was non-Hispanic white. There were individuals who were classified, self-identified as both non-Hispanic Black and non-Hispanic white, and a smaller percentage that were non-Hispanic Black. And overall, in this study population, as you might expect, in a group with high socioeconomic status, the preterm birth rate was much lower than the general population rate. It was at 6% overall, and a very low percent, 0.3%, less than 28 weeks. However, despite the fact that we were looking again at women of high socioeconomic status, we still noted that there were disparities in preterm birth. And interestingly enough, the disparities were highest for women who were non-Hispanic Black, but intermediate for women who self-identified as both non-Hispanic Black and non-Hispanic white, which are shown here in this, the middle set of bars. And those disparities and differences were significant at all gestational age cutoffs. Those differences and those findings held across in our regression models, where again, we still found that women who are non-Hispanic Black, despite being high socioeconomic status, well-educated, not on WIC, and having private insurance, were had the highest risk of preterm birth at all gestational ages. Women who were both non-Hispanic Black and non-Hispanic white race had intermediate risks. And again, this was all compared to non-Hispanic white women as the referent group. Another recent area of investigation that I've been pursuing has been looking at chemical stressors. So we've talked about like social stressors and environmental stressors from a standpoint of the composition of one's environment, where you live, with regards to the well-being of your neighborhood, or how well how well-to-do one's neighborhood might be. But there's also this whole other level or layer of environment, which is the actual exposure to different contaminants. And these are some data that were published from North Carolina back in 2012, looking at inorganic toxicants. So these were things like arsenic, cadmium, mercury, lead, heavy metals, to see whether or not, first of all, they're present in the blood of pregnant women. And indeed, yes, they were, which is kind of scary. They crossed the placenta, and indeed, they were found in various quantities in different counties, and lead was found in the blood of all women that were in this cohort of 210 pregnant women. And we did find differences where the rates of each one of these metals was higher in women of non-Hispanic Black race versus women of other races. Well, you might say, oh, well, maybe that's just North Carolina, but indeed, arsenic is a worldwide problem, and there is arsenic in drinking water, not just in the United States, which you might not, again, think about. And if you notice this part of the United States that we reside in, North Carolina is listed as having no data, but I've just shown you data that suggests that there is indeed exposure in drinking water to arsenic. And there are disparities in exposure to arsenic. And these metals are associated with adverse outcomes, possibly through mechanisms of altered DNA methylation, changing genes, controlling transcriptional regulation, and associated not only with preterm birth, but growth restriction, miscarriage, low birth weight, and other adverse pregnancy outcomes. So my last factor in the simplified schematic is genetics. I think we have a lot of evidence to suggest that preterm birth is heritable. This is based on the fact that we know that an individual has an elevated risk of preterm birth if they have a first-degree relative with preterm birth. We know that women who themselves have delivered preterm have an increased risk of recurrence. We know that if you have a sibling with preterm birth, you have an increased odds. And we know that twins have an increased odds. And the overall heritability is estimated between 25 and 40%. When I was in Utah during my fellowship and in my early years as a faculty member, we looked at some of the pedigrees within Utah, the Utah population database, and found that there are some very high risk pedigrees. And this is a truncated example of the pedigree where you can see that the children that were born preterm or individuals who were born preterm are kind of shaded with like the half box. And you can see that in this pedigree, extended pedigree, where these individuals probably don't even know they're related, there's just preterm birth kind of all over the place, which is pretty remarkable and suggestive again of some sort of genetic factor, at least here within this family. So even though preterm birth is heritable, this is not the only explanation, and I would say it's a minor explanation for the disparities, if at all. We know that Black women born in Africa and the Caribbean have lower preterm birth and lower low birth weights than US born Black women. So something about the pre-pregnancy experience or even the pregnancy experience of US born Black women is detrimental to their outcomes. We have further evidence of this when we look at intergenerational preterm birth recurrence. So I worked on this study with Marcella Smith, who's now at Utah, when she was a fellow, looking at the Virginia intergenerational linked birth file. We limited the study to non-Hispanic Black and white mothers, and they had to have singleton, non-anomalous pregnancies. The study included over 70,000 individuals. And we looked at basically what happened to the mother, and whether the mother herself was born at term or in the late preterm or in the very preterm period, what was likely to happen with her first pregnancy. So we found that moms who themselves were born at term had a lower risk at all of delivering a preterm baby at any gestational age. Moms who themselves were born in the late preterm period had a higher risk of preterm birth, and moms that were born very preterm had the highest risk of preterm birth. But you can see here again that the disparities are striking. So if we look at a non-Hispanic Black mother who herself was born less than 34 weeks, she has over a 3-fold increased odds of a preterm birth less than 37 weeks in her first pregnancy. So again, our reference group is a non-Hispanic white mother born at term. The higher rates of preterm birth were seen in mothers who themselves were born preterm, and those effects were most pronounced for non-Hispanic Black women and for those that were born earliest. So in summary, when we look at intergenerational preterm birth risk studies, most studies seem to suggest a positive relationship with risk ratios in the 1.2 to 1.5-fold range, with some references listed here. There are a few negative studies showing no association, but some of these data do seem very compelling. What about the influence of mother's genes and father's genes? And does it matter if mom is Black or if dad is Black, or both are, one is, one isn't, and that sort of thing. So there are a number of different studies that have tried to quantify the risk associated with specifically the mother's genes versus the father's genes. And this study was done in Norway, and they looked at records between parents and children, and basically they were able to discern that the gestational age of the child increased by 0.6 days for each additional week in the father's gestational age, and it increased for 1.22 days for each additional week in the mother's gestational age. So the mother seemed to be the most important as predictor of whether or not the pregnancy was delivered at term or not, but also the father did have an important contribution. Now, if we look at whether or not the couples of mixed race are important or have a different risk, we see that the data are consistent with that data from Norway, where it seems to suggest that the maternal race is the most important. So again, our referent group is a couple that is white, a white mom and a white dad. And then the highest risk group is a couple that is a Black mom and a Black dad, and purple, they have the highest risk of preterm birth. And there's an intermediate risk for individuals of or couples with mixed race, mixed race couples. And this is for preterm birth less than 28 weeks. Their results were similar in adjusted and unadjusted analyses, and also at various gestational age cutoffs. Even though I'm only showing the less than 28 weeks here, there were other cutoffs that were looked at, and the results were consistent. And again, this suggests an increased contribution of maternal genes. Others have also looked at whether or not there's genetic pathway differences. So Ram Menon has done a lot of research in this area, trying to see whether or not genotyping the mom and the baby finds differences in specific groupings of genes, kind of along the idea of some of the phenotyping that we were talking about earlier with regards to decidual hemorrhage or cervical insufficiency. And in this graph, they they basically concluded, you know, the dark bars here are maternal genotypes, and the light bars are fetal. And they found significant differences in the types of genes that seem to contribute to gestational age and birth outcomes, both between Caucasian and African American individuals, with inflammatory genes being the primary driver among African Americans, and dermatologic categories of genes or groupings of genes most important among Caucasians. Epigenetics is kind of the future, I think, of genomics and genetics, and particularly the study of the integration between the environment and the genetics, the genome, or one's genotype, one's DNA. And I think that a lot of individuals are maybe intimidated by the term epigenetics, but really it can be simplified, and I think it's really interesting and maybe part of the link between some of the things that we see with regards to stress and racism and the environment, as well as the genome and our outcomes. So epigenetics can be thought of as punctuation marks in the genome. They demarcate the start and the end of genes and provide structure to the chromosome, kind of like a paragraph break. Epigenetics, there's a number of different epigenetic changes, but they alter how genes are read and can lead to genes being expressed or not expressed. Epigenetics are heritable, but they're dynamic and possibly reversible. And basically, they provide a feedback between genes and the environment. So if we think about DNA, and then one acquires and has epigenetic marks that are either inherited or acquired. So if somebody is exposed to prolonged stress or even acute stress for a period of time, they might acquire an epigenetic mark at a point in their DNA. And that, again, that epigenetic mark is going to affect translation of RNA and protein expression, and then impact outcomes, and potentially even impact one's environmental stimuli, which then goes back and further impacts their epigenetic marks. CpG methylation is an example of one of the most commonly studied types of epigenetic modifications. So CpG methylation, sometimes I'll also refer to as DNA methylation, is when a methyl group is added to the promoter region of a gene, and it kind of like blocks the gene from being transcribed. And so then there's gene silencing, and demethylation can occur. So that little methylation mark can be removed in response to environmental stimuli. This might, again, provide some insight into some of the intergenerational risk in Black women, and also provide some insight into the relationship between stress and preterm birth risk among Black women. So in a study looking specifically at epigenetics in 2015, they found, these investigators found that there were certain sites enriched for association with preterm birth and maternal leukocytes, and these genes were involved in metabolic, cardiovascular, and immune pathways. And they concluded that that kind of was evidence for epigenetics' role in prematurity. Well, how do we bring all of these things together? I think if you didn't already feel this way prior to this talk, hopefully you do now. All of these things are interconnected and interrelated. Genes and the environment all contribute to phenotype. And if you try to create a diagram, it just quickly becomes even more complicated and confusing the more elements you try to integrate. But where do we go from here? With regards to racism, we urgently need valid, replicable, and sound measures of structural racism, sound measures to evaluate structural racism, to determine the extent of harm to health, and to identify pathways for intervention. I think this is a key priority, and I wish I had a great answer or solution to this. I know lots of very smart people are working on this, but we need to improve our ability to measure racism and move forward with reduction and elimination of racism. A lot of attention has been paid recently in obstetrics and maybe in other areas of research about race as a covariate. It's typically self-reported, and self-reported ancestry does have a high degree of correlation with genotypic ancestry. But again, race is a social construct. And so there's been a lot of attention and a move to disregard race as a risk factor. And, this gets really tricky. And I think when you're thinking about whether or not to include race in analysis, might consider leaving it in as a covariate, provided that you recognize what inclusion of race in your analysis means. It's really serving as a surrogate for factors that are more difficult to measure, again, like racism, in the vast majority of your studies. Furthermore, we need better phenotyping and a better understanding of pathophysiology. I think that oftentimes we say, oh, she had spontaneous preterm birth, but there's so much more to it than that. I think as we've talked about and demonstrated, and as you all know, there are a lot of different pathways to preterm birth and spontaneous preterm birth, and we need to have a better and more precise way to delineate those individuals. When we integrate phenotype and genotype, we find that there are clusters of individuals, and we might get to learn more. So what are the solutions? And I'm sorry, the slide is a little bit fuzzy. It looks messy because it is, because there are not any easy solutions. And it is hard to know exactly where to start or where to go. However, we need to start tackling some of these risk factors, some of the potential interventions that maybe can be addressed even prior to conception in order to think about preterm birth and reducing the disparities associated with them. So at UNC, we have a number of different prospective studies. We're trying to better quantify stress, collect comprehensive genetic data, self-reported and objective environmental exposure data, and better characterize phenotypes. And you all are helping us with the P3 study at UAB, and I'm very appreciative of that. So to conclude, socioeconomic, environmental, and genetic factors partially explain the association between preterm birth and race, but they don't entirely explain the difference. And most of the Black-white disparity remains unexplained by measured factors. And we must better understand the contribution of factors to disparities to preterm birth in order to prioritize actionable research aimed at eliminating disparities. Hopefully, sometime in the not too distant future, we'll be able to better individualize care to improve outcomes for those at highest risk, and really have targeted interventions for individuals so that we can reduce disparities and not just reduce preterm birth. And maybe if we could better understand disparities, we could better understand preterm birth. And if we successfully reduce preterm birth disparities, hopefully we can improve life trajectories for moms and improve long-term outcomes for women and help stop that cycle of intergenerational preterm birth. So I thank you for your attention. I wish I had an updated picture of my research team, but thanks to COVID, I do not. So I therefore have a screenshot from my website, and you can learn more about some of the research that we have going on here if you're interested at that web address. And I am happy to take any questions. I know that was a quick presentation on a lot of information, and I appreciate everybody's attention.
Tracy, thank you so much. Fantastic talk. I would go ahead and invite, I think we can take a few questions. Please feel free to turn on your camera or drop in a question into the chat box. So are there any questions for Dr. Manuck? I'll just briefly, one is, do these associations also apply to indicated preterm births?
So many of them do, particularly preeclampsia. You know, we know that Black women, for example, have a higher rate of preeclampsia, high rate of maternal morbidity, higher rate of baseline chronic hypertension, which again partly explains some of the differences there associated with preeclampsia and therefore indicated preterm birth, but don't explain all of the difference.
Okay, thank you. Questions? I have so many. I'm giving others the opportunity to ask. So there is one, is there any difference within the Black population regarding preterm birth, e.g. Black versus Black instead of Black versus white?
Yeah, so, you know, that's been something that we've looked at a little bit. And there have been some studies that, you know, have, you know, been performed to see whether or not like our traditional preterm birth risk factors hold when if you limited a population, your cohort to only Black women, if that's the question. So yeah, so based on environment or insurance. And you know, if we look at US-based studies, again, like focusing on individuals who are here in the United States and have been here and not looking specifically at, you know, recent immigration to the United States, that sort of thing, because those studies have shown that, you know, coming to the United States, you have a lower risk of preterm birth. Like if you are, you know, first generation versus have been here for a while, you have the first generation individuals have a lower risk when that population is isolated to individuals with individuals of Black race. But if in studies that have looked at only Black individuals and then tried to see whether or not those social factors still hold, in the majority of the studies that I've seen, they do.
Great. So I'm going to ask one about prenatal care, just to get your thoughts, because there was a study several years ago from Parkland where they saw these lower rates in in Hispanic women and attributed that to better prenatal care, and we had a debate around that. Recently, we've done a analysis, you know, using our population and looked at different markers of the quantity of prenatal care that they got, and surprisingly, we found prenatal care to be associated with, you know, more quantity of prenatal care with a lower risk of preterm birth, spontaneous preterm birth. Any comments or thoughts? Is this something you've looked at?
Yeah, so we have looked at that, and I think, you know, others have also found, you know, earlier prenatal care and more prenatal visits, adequacy of prenatal care, which you know, is hard to define, but is defined by ACOG based on like a number of visits, you know, based on gestational age of delivery, and then also gestational age at initiation of prenatal care is associated with improvement in outcomes. But even there, we still haven't seen and haven't been able to completely resolve that, you know, that disparity. Even within the study that we did that I mentioned among women of high socioeconomic status across the US, you know, we found that the gestational age at initiation of prenatal care was similar between Black women and white women. And we did a sensitivity analysis where we isolated or restricted the population, study population, to only individuals who got prenatal care in the first trimester, and we still found the same results. So in that cohort, at least, we still found those disparities. We did not directly compare, however, those individuals with the few people in that cohort who had gotten later prenatal care.
Thank you. I think we'll take one final question and then turn it over. If there is an announcement. So, and you can see this, is there any role for IVF to help mitigate some of the risk of preterm birth? Is that an appropriate step?
That's a good question. However, if you look at the IVF data, IVF itself is actually associated with a higher risk of preterm birth. And that itself is poorly understood. And it may have something to do with the underlying population or reason for seeking infertility care. But I don't know that that's well understood at baseline. And so I unfortunately, I don't think that will be a solution.
Thank you. And I would like to take Dr. Fowler's question on this very important topic. Are there stress biomarkers that could be measured easily, not incredibly expensive during pregnancy, that could be implemented in studies?
Yeah, no, that's a really good question. I actually am writing a grant that's due next week that's looking at stress biomarkers. So I'm pretty up on the different options, having just reviewed them as well as the prices. There's not anything good from a clinical utility standpoint at this point, but if you're talking about from a study standpoint, there are a number of different biomarkers that you can look at. In maternal blood, you can look at, interleukins and cytokines in cervical vaginal fluid. You can look at things in urine, and there are assays that are not terribly expensive. I mean, just running like a Luminex assay or something along those lines that looks at interleukins is not expensive at all. There are also assays looking at oxidative stress and DNA damage that can be accomplished, through a simple like ELISA methods and that sort of thing.
All right, and Karen, you can reach out to Dr. Manuck if you want to get more information about this. So, on that note, thank you so much for a terrific talk. Really appreciate you sharing your expertise with us, and good luck with the grant going in, and be safe. Thank you.
Thank you, guys.
All right. Thank you. Back to you, Christy.